Some interesting cases, first of all.
Yeah.
So this is a 37-year-old female admitted with pyrexia of unknown origin. Counts were completely normal, but there was some lymphocytosis shift to left in the blood picture. Manto was negative, X-ray chest was normal, and blood cultures were negative. So, Rima, I would just want to ask you, how would you proceed in this case? This is a case where there's an exudative retinal detachment inferiorly, but almost something like a subretinal abscess here, and there was pyrexia of unknown origin as well. They are not able to, come to a diagnosis. They are asking the ophthalmologist what to do about this.
Do we have the HIV report?
HIV was negative actually.
And the CBC?
CBC was, counts were normal, but there was a shift to left. Lymphocytosis, predominant lymphocytosis.
Patient is stable neurologically?
Neurologically stable, fever is there, some cactication is there, emaciated look.
So,
and
here the X-ray chest is done. I would rather get a CT chest.
CT chest, yes.
Or maybe if there is slight, systemically, sometimes the patients don't look that comfortable. So I would go for a PET CT. I'm in a center where I can afford PET CT, but I would advise that for everyone.
All right. But this patient underwent a vitreous biopsy as well. Okay. And we got tuberculosis from this, and we treated her for tuberculosis. And the retinal condition also subsided with poor visual recovery. This was actually an abscess. So if this abscess were to be in the periphery, would you consider draining the abscess or something like that and see what is there? Will you get a positive culture?
No. So generally in tubercular abscesses, we don't really operate. We treat them with intravitreal anti-VEGF, along with anti-TB therapy, along with steroids. And biopsy, usually if the PCR is positive, which is unlikely. Did you get AFP from this?
No, we did PCR positive.
Just the PCR was positive. So if we have a tubercular subretinal abscess, the only way we intervene is in the form of anti-VEGF intravitreal, and we treat them with oral steroids and anti-TB therapy.
Okay. This next case is a dysthyroid ophthalmopathy. This patient had papilledema both eyes, and basically the patient had a decrease of vision as well. And you can see that all the muscles are, constricting the optic nerve. And this is a patient in whom dysthyroid ophthalmopathy, there was proptosis also in this patient. So just to say myriad of causes of disc edema, one of the things is, this thing as well. It's a very interesting case actually, carotid insufficiency. This patient had a vitreous hemorrhage. I operated him with a poor visual recovery. You can see that there is a seeming cherry red spot sort of appearance in that particular eye which had a vitreous hemorrhage.
Operated for what?
Vitreous hemorrhage.
Vitreous hemorrhage, okay.
Yeah. And when I did the other eye fluorescent angiography, you can see this large area of non-filling area around the any thoughts, Mahesh? The other eye. So this patient had carotid occlusion actually, both eyes. So maybe it was secondary to that. I think we have crossed the time. Let me thank all my co-instructors and the audience for having this wonderful instruction course. Thank you.
Thank you, Gopal.